Welcome to the Funnel Effect.
Glad to be here.
So our source material for this deep dive is a really landmark state-of-the-art review. It's titled, Proposed Standardized Nomenclature for Anomalous Aortic Origin of a Coronary Artery.
Right. Published in JCC Cardiovascular Imaging in 2026.
Exactly.
Yeah.
And because this document represents just a massive unified effort from multiple disciplines all over the globe, we are actually going to read the full list of authors right at the top.
Yeah, they deserve the credit for this one.
They really do.
Yeah.
The authors are Carlos M. Mary, Meena Nathan, Christoph Grenny, Rajesh Krishnamurthy, Christina Basso, Marshall L. Jacobs, Julie A. Brothers, Massimo A. Padalino, and Silvana Malassi.
It's just a remarkable assembly of talent, you know?
Wow.
You have an international roster of absolute heavy hitters.
Right, from completely different fields.
Yeah, representing adult cardiology, pediatric cardiology, cardiac surgery, advanced imaging, morphology. I mean, getting all of these distinct specialties to agree on anything is an achievement in itself.
It really is. And that team's mission is exactly what we're decoding today. We are looking at a document that solves a massive, potentially lethal communication problem in the medical field.
A literal Tower of Babel situation.
Completely. The mission today is to explore the new universal language of the heart's hidden anomalies, right? And to understand how a simple change in terminology, like how doctors literally spell out a diagnosis, could be the difference between a young athlete living a full life or, suffering sudden cardiac death on the field.
It's wild to think about it that way.
It is. I mean, think about it. Have you ever tried to coordinate a complex project where everyone in the room is using a completely different language?
Sounds like a nightmare.
Right. Now imagine that project involves planning an open heart surgery or trying to calculate the statistical risk of a teenager's heart failing during a marathon. That is the exact crisis this document aims to solve.
And it really forces us to reevaluate how we think about medical breakthroughs, I think.
How so?
Well, we're so conditioned to associate medical advancement with a tangible piece of new technology, right? Like a better MRI machine or a robotic surgical arm or some novel pharmaceutical drug.
Yeah, the shiny new toy.
Exactly. But the advancement here is pure language. It's grammar. It's syntax. Because if the surgical team and the radiology team do not share a mathematically precise language,
Then all the high-resolution scans in the world don't actually help.
right, they're essentially just noise.
So before we dive into the solution, which is this incredibly intricate modular naming system, I feel like we need to establish what is actually at stake anatomically here.
Yeah, we need to look at the climbing.
Let's do it. We are talking about congenital coronary artery anomalies, and specifically one condition abbreviated as AAOCA, anomalous aortic origin of a coronary artery.
So to understand the gravity of AAOCA, we really have to visualize the normal plumbing of the human heart.
Okay, set the scene for us.
Right. So the heart is a tireless, continuously beating muscle, right? And like any muscle in the body, it requires a constant, uninterrupted supply of oxygen-rich blood.
Makes sense.
But what many people don't realize is that the heart cannot extract oxygen from the vast pools of blood pumping through its own internal chambers.
Wait, really? It's literally full of blood but can't use it.
Yeah, the walls are just too thick. It can't absorb it that way. It requires its own dedicated external irrigation system.
Oh, I see. Those are the coronary arteries that wrap around the outside of the heart muscle, right?
Correct. And the architecture of a normal heart is an incredibly efficient design. The main pipe carrying all that highly oxygenated blood out of the heart's left ventricle to the rest of the body is the aorta.
The big one.
The big one. And at the very base of the aorta, right where it attaches to the heart, there's a root with 3 little bulbous pouches. We call these the sinuses of Valsalva.
Okay, sinuses of Valsalva.
Yeah. In a healthy, typical heart, the right coronary artery branches perfectly off the right-sided sinus, and the left coronary artery branches perfectly off the left-sided sinus.
But with AAOCA, those blueprints kind of get scrambled during fetal development.
That is the core issue, yeah. It's a congenital anomaly, meaning the patient is born with it. The coronary arteries just originate from the wrong location on the aorta.
Right.
You might have the right artery originating from the left sinus, or maybe both arteries sprouting from a single trunk on one side, and because they originate from the wrong postal code, so to speak, they have to take an abnormal, sometimes highly dangerous physical path to reach the heart muscle they're supposed to feed.
I was thinking about how to visualize this for you, the listener, and it really reminds me of a severe residential plumbing error.
Oh, I like this.
It's like finding out the main water line to your house, wasn't buried safely under the yard, but was accidentally installed straight across the concrete of your driveway.
Right.
For years, you might never know. You turn on the kitchen tap, water comes out. It functions perfectly. But the vulnerability is hidden. Because one day, someone parks a heavy delivery truck directly on the driveway, the pressure crushes the pipe, and suddenly you have a catastrophic, instantaneous failure of the whole system.
That analogy perfectly captures the terrifying unpredictability that cardiologists face with this condition. I mean, the medical literature explicitly highlights this management dilemma.
It's just so random.
Exactly. The physiological consequences of AAOCA run the entire spectrum. At one end, it has absolutely zero physiological impact.
None at all.
None. It's just an incidental finding on a scan that will never bother the patient for their entire life. But at the other end of the spectrum, it triggers catastrophic, life-threatening, ischemic, or arrhythmic events.
Let's contextualize how often this actually happens. The text states that AAOCA occurs in roughly 0.2% to 0.7% of the general population.
Which doesn't sound like a lot.
Right. At a glance, a fraction of a percent sounds like a rare medical footnote.
It sounds rare until you apply that percentage to real-world crowds.
Yeah.
Think about it. Imagine a packed college football stadium on a Saturday. 100,000 people in the stands.
Okay.
Statistically, you are looking at between 200 and 700 individuals sitting in those seats who have this anomaly.
Wow. That really puts it in perspective. That is a substantial number of people walking around with a potential structural defect in their heart.
And the stakes for that specific group are outlined in a really sobering statistic from the paper. According to autopsy studies, AAOCA is the second leading cause of sudden cardiac death in young competitive athletes.
Second leading cause. That's chilling.
It is the reality that haunts pediatric cardiologists. We are talking about young, incredibly fit, ostensibly perfectly healthy teenagers or young adults.
People who are at the peak of their physical health.
Yeah. They have no symptoms, no warning signs, and then, usually in the middle of intense physical exertion, like a basketball game, a track meet, a soccer match, their cardiac demand spikes.
All right, their heart is pounding.
And that abnormal blood vessel becomes compressed, and the heart is starved of oxygen instantly.
Which begs the obvious question. I mean, if this anomaly is the second leading cause of sudden cardiac death in athletes, and we know it affects hundreds of thousands of people, why hasn't the medical establishment figured out a standardized way to track it, study it, and prevent it before now?
Well, the barrier hasn't been a lack of caring or a lack of technology.
What was it then?
The barrier has been a fractured, siloed medical culture.
Ah.
Think about it. To figure out which variations of AAOCA are the harmless pipes under the yard and which are the ticking time bombs under the driveway, you need massive international databases.
You need tons of data.
Exactly. You need to track thousands of patients over decades to see what actually happens to them. But you cannot compile a functional database if every single hospital describes the anatomy using a completely different set of rules.
Looking at the history outlined in the review, it honestly reads like the Tower of Babel. It seems like every 10 years, a different group of doctors invented their own mapping system, published it, and just refused to adopt anyone else's.
It's a classic consequence of extreme medical specialization. Different doctors view the heart from completely different physical and philosophical vantage points.
Right.
Take the Leiden Convention, proposed in 1983. It was an alphanumeric coding system originally designed for a completely different heart defect, but it worked brilliantly for a cardiac surgeon.
Because of the physical angle they're looking at, right?
Yes, exactly. A surgeon operates on an open chest. They are standing above the patient, looking down at the top of the heart, a cranial view.
Okay.
From that top-down perspective, the Leiden system's mapping of the aortic root was highly intuitive for them.
I'm going to play devil's advocate here, though. If I'm the surgeon holding the scalpel, and my primary concern is what I see when I crack the chest, why should I care about changing my naming system?
Fair question.
Right. Like, why should I be forced to adopt a new vocabulary just to make a data spreadsheet look cleaner? Isn't forcing a surgeon to use an unfamiliar map actually dangerous?
It is a totally valid concern, and it's exactly why the resistance to change lasted for decades. But the flaw in that logic is that the surgeon is almost never the one discovering the anomaly.
Oh, interesting.
Right. The anomaly is usually discovered by a radiologist reading an MRI or a CT scan weeks or even months before the surgery. And a radiologist does not view the heart from the top down.
Right. They're looking at screens.
They view it in cross-sectional slices, traditionally from the bottom up, a caudal view.
So the surgeon's intuitive top-down map is practically upside down and backward for the radiologist looking at the screen.
Exactly the problem. If the radiologist uses a naming system the surgeon finds counterintuitive, the surgeon might fundamentally misunderstand where the vessel is located before they even make the first incision.
That sounds terrifying.
It's not ideal. In 2022, there was an attempt to fix this with the imaging Leiden Convention, which incorporated the radiologist's perspective, but that just added another dialect to the mix.
Yeah, and there were plenty of other dialects out there. The text mentions Paolo Angelini's work in 1989, classifying anomalies by origin and emphasizing the concept of wrong sinus origin.
Right.
Then you had the International Pediatric and Congenital Cardiac Code, the IPCCC, introduced in 2000, updated in 2010. It was even added to the World Health Organization's ICD-11 coding system in 2021. And if that wasn't enough, the European Society of Cardiology created their own embryology-based system in 2016.
It created an absolute crisis in the clinical data. The text highlights how this total lack of standardization led to multiple, wildly different labels being applied to the exact same anatomical variant.
Just total chaos.
Basically. If a research hospital in Milan uses the European consensus, and a pediatric center in Boston uses the IPCCC, and a clinic in Texas uses Angelini's classification, their data cannot communicate.
They're speaking Italian, English, and Spanish.
Exactly. You cannot run a statistical analysis to find the risk of sudden death if you cannot even agree on the name of the condition you are studying.
So how do you force brilliant, highly specialized, and historically stubborn experts to finally agree on a single language? Because that leads us to the creation of the Collaborative Task Force. In December 2022, they formed the ICAC, the International Coronary Artery Anomalies Collaborative.
The formation of the ICAC was a very deliberate attempt to break down those silos once and for all. They assembled 10 global experts, 7 from the US, 2 from Italy, and 1 from Switzerland.
A real all-star team.
Yeah. They intentionally drafted representatives from every warring faction, adult cardiology, pediatric cardiology, surgery, and advanced imaging, and they put them all in a virtual room to hammer out a unified standard.
Their goal was to create a strictly anatomical nomenclature, but the specific phrase they used to guide this process really caught my attention. They insisted the new language must be risk agnostic.
Yes, that principle is arguably the most profound philosophical shift in the entire document.
How so?
Well, for decades, when doctors named these anomalies, they had a terrible habit of baking their clinical fears directly into the terminology.
Which makes sense from a human perspective.
Yep.
Usually, if humans find something dangerous, we put the warning label right in the name. We call it a widowmaker or a fatal flaw.
Right.
But the ICAC is saying, we are just going to name the parts of the engine, and we are absolutely refusing to say whether the engine is going to explode.
Exactly. Because baking the assumption of risk into the name inherently biases the data pool.
Give me an example of how that bias plays out.
Okay, consider a hypothetical scenario. A 15-year-old girl gets a chest scan for a minor murmur, totally unrelated to this, and the radiologist notes a coronary anomaly.
Okay.
If the radiologist is forced to use an older naming system that labels her specific anatomy as a high-risk variant, the pediatrician reads that report and immediately benches her. She is banned from playing high school soccer.
Even if she has never had a single symptom in her life.
Yes. She becomes a medical statistic of a high-risk patient simply because the naming convention told the doctor she was high risk. It becomes a self-fulfilling prophecy.
Wow.
The ICAC recognized that we don't actually have enough long-term data to know for sure if her specific anatomy is truly dangerous.
We're just guessing based on old assumptions.
Exactly. By making the terminology risk-agnostic, doctors are forced to objectively describe the physical shape of the heart without passing a premature death sentence. The objective is to gather massive amounts of pure, unbiased physical data first. Later, algorithms will look at the outcomes and objectively tell us what is actually dangerous.
I love the discipline of that approach.
Yeah.
But getting 10 prominent doctors to adhere to that discipline seems like herding cats. I mean, the text details their methodology, and they use something called the Rand-modified Delphi technique.
Yeah.
How does that actually work in practice?
It's brilliant, really.
Because usually if you put 10 senior experts in a room, the person with the loudest voice or the most prestigious title just dominates the conversation and bullies everyone into their preferred system.
That exact dynamic, the dominance of ego and hierarchy, is what the RAND-modified Delphi method was designed to completely eliminate. The technique has been refined over the last 5 decades specifically to achieve true expert consensus by systematically stripping away group bias and peer pressure.
How do they physically do that, like logistically?
It relies on absolute anonymity and iterative voting. The ICAC started by establishing a baseline, looking at all the published literature and holding some preliminary discussions. Then, the facilitators drafted a set of highly specific expert consensus statements.
Okay.
But instead of debating these statements on a Zoom call where the most famous surgeon could sway the room, they used a secure, cloud-based system to cast anonymous votes.
So a younger radiologist in the group has the exact same voting power and total protective anonymity as a world-renowned cardiac surgeon who might have been doing this for 40 years.
Precisely. They log in, they vote on a scale of appropriateness, and crucially, they are required to provide anonymous, detailed written feedback explaining exactly why they agree or disagree with the phrasing.
Oh, so you can't just vote no, you have to defend it.
Right. And then the facilitators collect all this blinded data, revise the statements to address the specific criticisms, and then send the new version back out for another round of anonymous voting.
The text notes that to validate a statement, they required over 80% of the experts to vote, and over 80% of those votes had to be in agreement. They ran this process through monthly virtual meetings spanning an entire year, from December 2022 to December 2023.
It was a grind.
And the result is astonishing. By the fifth round of voting, they achieved 100% agreement on the final validated nomenclature.
Achieving 100% consensus among 10 experts from completely different subspecialties is virtually unheard of in medicine.
I can imagine.
It really speaks to the rigorous, ego-stripping power of that Delphi method. They didn't just find a compromise where everyone was slightly unhappy, they forged a system that every single one of them fundamentally believed was structurally sound.
So let's look at the actual language they built. Now that they've agreed, what is the grammar of this new medical language? It starts with a foundational building block they call the core descriptor.
The beauty of this nomenclature is its modularity. It is a hierarchical system. A doctor can tailor the report to be as broad or as pinpoint detailed as the available imaging allows. But every single diagnosis must start with the core descriptor.
Reading through this, it feels exactly like standardizing a postal code for the heart.
That's a great way to think about it.
Yeah, to make it a valid address, the core descriptor demands 4 mandatory components: the anomalous vessel, the term AOCA, the signs of origin, and the proximal course.
That postal code analogy holds up remarkably well under scrutiny. Let's walk through the components.
Okay, so the anomalous vessel is essentially the name of the person receiving the mail. AAOCA is the state they live in. The sinus of origin is the city, and the proximal course is the specific street they live on.
Brilliant way to frame it. Starting with the person's name, the vessel itself. The nomenclature dictates highly specific prefixes to identify which artery is acting abnormally.
Right.
You use R for the right coronary artery, L for the left main coronary artery. If it's a specific branch, you use LAD for the left anterior descending, or LCX for the left circumflex. And finally, ST for a single trunk.
Before we talk about the rest of the address, we have to talk about the old terminology they explicitly outlawed here. Because when you enforce a new language, you have to actively ban the old slang, right?
Oh, absolutely.
They specifically targeted and eliminated the acronym ACAOS, ACAOS, which stood for Anomalous Coronary Artery from the Opposite Sinus.
Banning ACOs was an essential step in enforcing the risk-agnostic philosophy.
Why is that term so problematic?
For years, ACAS was used to describe a scenario where, for instance, the right coronary artery originated all the way over on the left sinus, the opposite side of the aorta. The historical perception in cardiology was that originating from the opposite sinus was the primary mechanical driver of sudden cardiac death.
Going back to our 15-year-old athlete, if she had that anatomy, the doctor would slap the ACAOS label on her file, and everyone would assume she was in imminent danger.
Yes. The ICAG recognized that forcing doctors to use the term ACOs actively harmed the diagnostic process in 2 ways. First, it baked the assumption of high risk into the name, which, again, we want the long-term data to prove, not assume.
Right.
Second, it created a massive blind spot. If doctors are trained to only look for danger when the artery comes from the opposite sinus, they might ignore severe risks associated with anomalies originating from the same sinus or non-facing sinuses.
Ah, so they might miss a dangerous anomaly just because it didn't fit the acronym?
Precisely. So the new rule is uncompromising. Throw out ACOs completely. The universal state they live in is AAOCA, regardless of which sinus is involved.
They also banned the use of the word cusp to describe the origin. Some older reports would say an artery originated from the left cusp.
That ban is purely about anatomical precision. The cusp, or leaflet, refers to the actual flapping tissue of the aortic valve itself that opens and closes with every single heartbeat.
The doors of the valve.
Right. The coronary artery does not grow out of that moving flap. It grows out of the bulbous wall of the aorta just above it. So anatomically, you must say it originates from the sinus, never the cusp.
Makes total sense. Now, there's another major terminology shift here regarding the prefix ST. ST stands for single trunk. In some variations of this anomaly, a single massive pipe comes off the aorta and then branches into all the major right and left coronary arteries. The old slang for this was a single coronary.
Right.
Why is single coronary wrong? If there's only one hole in the aorta, isn't it a single coronary?
It's a profound misunderstanding of the heart's development. While there may be only one ostium 1 hole on the aorta, the heart still possesses 3 distinct major coronary distributions: the right, the LAD, and the circumflex.
They still exist.
They exist, they were just all feeding off one initial trunk. More importantly, older conventions used to label this a left AOCA if the trunk happened to originate on the right sinus.
I can see the logic there. If the single trunk is on the right sinus, the doctor assumes the right artery is home where it belongs, and only the left artery is visiting from the wrong side of town. Therefore, only the left artery is anomalous.
But the experts at ICAC tore that logic apart by looking at the fluid dynamics and embryology.
How so?
If the entire coronary system is being fed by one single trunk, the blood flow dynamics for the entire heart are radically altered. The right coronary artery's flow is not normal just because its trunk happens to sit on the right sinus.
Oh, because it's sharing a pipe with everyone else.
Exactly. The entire origin point for the whole system is anomalous. Therefore, the mandate is to use the prefix SDAAOCA to capture the systemic nature of the anomaly.
Got it. So we have the person's name, the vessel prefix like R or L or ST. We have the state, which is AAOCA. Next up is the city, the sinus of origin.
The sinus of origin is attached as a suffix directly following the AAOCA term, separated by a forward slash.
Simple enough.
The designations are straightforward. RS indicates the right sinus, LS indicates the left sinus, and NS is used for the non-facing or non-coronary sinus, which usually sits more toward the back.
But the text gets incredibly granular here about vertical height. It notes that even normal, healthy coronary arteries can sometimes originate slightly higher up on the aorta, just above the sinus. At what point does a high origin become a certifiable anomaly that needs to be tracked?
This is where the nomenclature demands strict mathematical thresholds, anchored by a landmark called the sinutubular junction.
Okay, visualize that for us.
If you look at the root of the aorta, the sinuses are bulbous, like a clover leaf. But just above them, the aorta narrows into a straight ascending tube. That transition line is the sinutubular junction.
So how high above that line is considered abnormal?
For adults, the ICAC set the limit at 5 millimeters. If the artery originates up to 5 millimeters above that sinutubular junction, it is still considered normal variance, and you name it based on the sinus located directly below it.
Okay.
But for children, whose hearts are much smaller, a flat 5 millimeter rule wouldn't work.
Right, because 5 millimeters on an infant's heart is massive.
Exactly. So for pediatric patients, they use a proportional threshold. If the artery originates higher than 20% of the total depth of the sinus itself above the sinutubular junction, it trips the wire.
Got it.
If either of those thresholds are crossed, greater than 5 millimeters in adults or greater than 20% in children, the origin receives a new distinct designation, HO, which stands for high origin.
So practically speaking, instead of writing RAAOCARS, a doctor would write RAOCAHO and then RS in parentheses. This instantly tells anyone reading the file that the right artery is originating dangerously high above the right sinus.
And that HO designation is a massive red flag for a cardiac surgeon.
Why is that?
A high origin fundamentally alters the physical geometry of the aorta. If a surgeon needs to cross-clamp the aorta to stop blood flow during a procedure, or if they need to route an artificial bypass graft, an artery sitting high up on the tubular section is right in their surgical field. It completely changes the risk profile of the operation.
Okay, let's finish the core descriptor. We have the vessel, the AOCA tag, the sinus. The final mandatory piece is the street address, the general proximal course.
The street they live on.
Exactly. Once the blood passes through the wall of the aorta, What immediate path does it take? The text lists 5 courses: IM for intramural, IA for intraarterial, IS for intraseptal, PP for prepulmonic, and RA for retroaortic. We are going to explore the severe dangers of these paths shortly, but for the core descriptor, the doctor just appends the abbreviation to the end.
That completes the foundational postal code.
So what does a finalized one look like?
It looks like this: RAAOCALSIM. In one tight, standardized string of characters, you have communicated the fundamental architecture of the defect. An anomalous right coronary artery originating from the left sinus, taking an intramural course.
That's incredibly clean.
Any cardiologist in any hospital in the world can read that and instantly know exactly what they're dealing with.
It is brilliantly efficient. But if I am a surgeon standing over a patient preparing to cut into the aorta, a street address isn't enough. I need to know exactly where the front door is located on the street, I need to know what shape the door is, and I need to know what the immediate neighborhood looks like.
Right, you need the blueprints.
Which brings us to the next layer of the nomenclature: the additional descriptors, designed to map the origin in exhaustive detail.
To ensure radiologists and morphologists capture every minute detail the surgeon needs, the ICAC provided an overarching acronym, OCDA.
OCDA, what does that stand for?
It stands for Ostium Characteristics, Course Details, Dominance, and Additional Findings. It acts as a mandatory checklist.
Let's start with the O. Ostium characteristics. The ostium is the literal front door, the hole on the inside wall of the aorta where the blood enters the coronary artery. And there is a subacronym nested here: LORM, LRM, location, relationship, morphology.
The level of precision in LORM is just astounding. Let's look at the L for location. Even though the core descriptor already told us the artery originates in the left sinus, that sinus is a large, three-dimensional curved surface.
Oh, yeah.
Telling a surgeon it's in the left sinus is like saying the door is somewhere on the west side of the building. It isn't precise enough.
To solve this, the ICAC introduced a topography map. It is essentially a standardized grid system projected onto the 3D organic geometry of the aortic root. Figure 2 in the text displays this map, and it operates on 2 axes: circumferential location, meaning around the circle, and craniocaudal location, meaning the vertical height.
Let's break down the circumferential mapping first. They assigned a numerical value to each sinus to maintain consistency with older pediatric conventions. The right sinus is 1, the left sinus is 2, and the non-facing sinus is 3.
Okay.
Then they divide each individual sinus into 3 segments, A, B, and C.
So segment B represents the vast middle 50% of the sinus. Segments A and C represent the outer 25% margins on either side as you approach the commissures.
Exactly.
And the commissures, just to clarify for the listener, are the physical corners where the 3 leaflets of the aortic valve meet and attach to the wall.
You've grasped the exact layout. So if a radiologist spots an ostium right smack in the middle of the left sinus, its circumferential coordinate is 2B. If it is tucked way over into the far right corner of the right sinus, right next to the commissure, it might be 1A or 1C.
That covers the horizontal position. Now for the vertical axis, the craniocaudal location, they mapped the height using Roman numerals: I, 2, 3, 3, and 4.
The vertical mapping correlates deeply with the structural tissue of the aorta. Level 1 is low down, deep within the bowl of the sinus, staying below the height of the commissures.
Yeah.
Level 2 is an incredibly fascinating structural zone. It sits between the height of the commissures and the sinotubular junction. The text makes a point to note that level 2 corresponds to an area where the tissue of the aortic wall naturally thickens.
They call that thickened area the intercoronary pillar.
Yes, and that pillar is not just anatomical trivia. If the anomalous artery originates in level 2 and has to travel behind or through that thickened pillar, the sheer density of that tissue could play a significant role in compressing the artery during every heartbeat.
Because it's literally squeezing through a thicker wall.
Exactly. So knowing the origin is at level 2 provides vital clues about the mechanical risks the artery faces.
Moving further up, level 3 encompasses the area from the sinotubular junction up to that 5 millimeter or 20% threshold we established earlier. And finally, level 4 is anything above that threshold, which triggers the high origin warning label.
When you combine the horizontal and vertical coordinates, you generate a surgical GPS coordinate. The text offers a prime example. Imagine an anomalous right coronary artery arising from the left sinus, positioned just slightly to the left of the commissure, but below the sinotubular junction.
Let me test my knowledge here. So left sinus means 2. Just to the left of the commissure means it's in the outer margin, so A. And below the junction means level 2. You get a map coordinate of 2A2.
That is the power of the map. A radiologist types 2A2, and the surgeon halfway across the world knows exactly where to point the scalpel.
But what happens when the underlying anatomy doesn't match the standard 3-sinus map? I was wondering about patients with a bicuspid aortic valve. This is a relatively common congenital defect where the patient only has 2 valve flaps instead of the normal 3.
It happens quite a bit, yeah.
If they only have 2 flaps, how does a grid based on sinuses 1, 2, and 3 work?
The ICAC foresaw that complication and instituted a very specific rule. If a patient has a bicuspid valve, but the surgeon or radiologist can still clearly recognize the physical shape of 3 distinct aortic sinuses, which often happens if 2 of the leaflets are just fused together, they continue to use the standard 1-2-3 map.
But what if the aortic root is genuinely deformed and truly only possesses 2 sinuses?
If there are strictly 2 sinuses, the rule is to drop sinus number 3 completely. The map only utilizes sinus 1 and sinus 2.
How do they assign them?
The designation is based entirely on anterior-posterior orientation. Sinus 1 is defined as the most anterior sinus, the one physically closest to the front of the patient's chest. Sinus 2 is the most posterior.
And if they're side by side?
In cases where the 2 sinuses are perfectly aligned side by side, left and right, the right-sided sinus assumes the sinus 1 designation, and the left becomes sinus 2.
It's a highly adaptable system. So that covers the L and lorem location, the exact grid coordinate. Now we shift to the R-osteo relationship. Why is the relationship between the doors so important?
Because in cases of AIOCA, it is exceedingly common to have more than one coronary artery originating from the exact same sinus. The surgical team needs an absolute understanding of how those 2 front doors relate to each other.
Okay.
The ITIC standardized a 4-type classification system to describe this architecture.
Type 1 is the simplest. It means there are completely separate coronary ostia, 2 distinct holes on the wall of the aorta well apart from each other.
Right.
Type 2 means they are separate, but adjacent. The 2 doors are physically touching or right next to each other on the wall.
Type 3 and Type 4 are where the anatomy becomes really treacherous and where the nomenclature is absolutely vital. Type 3 indicates a single ostium, only 1 hole on the inside of the aorta. But immediately inside the dense wall of the aorta, that single pathway bifurcates into 2 separate vessels.
So, to use the house analogy again, you walk through a single front door, but while you are still standing inside the thick masonry of the front wall, the hallway splits into a left tunnel and a right tunnel.
A perfect visualization. Type 4, on the other hand, is also a single ostium, but it remains a single unified trunk as it travels all the way through the aortic wall and exits completely into the mediastinum, the space outside the heart.
So it doesn't split until it's outside.
Exactly. It only bifurcates into separate coronary arteries once it is completely clear of the aorta.
This circles back to our earlier discussion about the core descriptor prefix ST for single trunk. Does that ST label apply to both type 3 and type 4, since they both start with only 1 hole?
The text is adamant about this distinction. Only type 4 represents a true single trunk anomaly. Because in type 3, the vessels branch while still trapped inside the wall, they are structurally considered separate anomalous vessels that just happen to share a doorway. Type 4 is the only anatomical variation that earns the systemic STAAOCA prefix in the main postal code.
That granularity is incredible. Okay,
Yeah.
we have the location L and the relationship R. Now we arrive at the M in lorem osteomorphology. What does the door actually look like?
The morphology, or the physical shape of the ostium, is suspected to be a massive determinant of the hemodynamic consequences.
Because of flow.
Yes. To put it simply, a misshapen door makes it harder for blood to get out. The ISAC standardized the description of the shape by looking at the geometric ratio between the major axis, the longest width, and the minor axis, which is the shortest height of the opening.
They formalized 4 distinct shapes: round, oval, slit-like, and hypoplastic.
A round ostium is the healthy baseline. The minor axis is roughly equivalent to the major axis. It functions as a perfect circle, allowing maximum flow. An oval ostium indicates the minor axis is compressed, measuring between 50 and 90% of the major axis.
To visualize this for the listener, imagine a perfectly round concrete tunnel. That is your round ostium. Now imagine a bulldozer drives over the tunnel and crushes it from the top.
Great analogy.
If it's crushed halfway down, so it is noticeably wider than it is tall, but still clearly open, that is the oval morphology.
And if the bulldozer continues to press down, crushing the tunnel almost completely flat.
That brings us to the slit-like morphology. The strict mathematical definition for slit-like is when the minor axis is less than 50% of the major axis. It is severely, dangerously flattened.
The final classification is hypoplastic. This describes an ostium that might be perfectly round. The vertical and horizontal dimensions are equal, but the entire opening is miniaturized.
Oh, so it's just tiny.
Yeah, it is significantly disproportionately smaller than the normal coronary vessel it is supposed to feed. It's like trying to fill a fire hose through a pinhole.
Just visualizing that flattened, slit-like tunnel makes you realize how incredibly difficult it would be for the heart to pull enough blood through that opening, especially when an athlete's heart rate triples during a sprint.
It's a huge bottleneck.
But this brings us to another fascinating example of the ICAG aggressively banning old terminology to protect their risk-agnostic philosophy. They explicitly outlawed the use of the term stenotic ostium.
This prohibition strikes at the heart of the psychology of medical reporting. The word stenotic literally translates to narrowed, but in the culture of cardiology, it carries massive physiological baggage.
Like Aki guessed it.
Exactly. Stenosis implies a functional, active flow problem. It implies disease, resistance, and immediate danger. If a radiologist types stenotic ostium into a chart, the downstream assumption by the pediatrician is that blood flow is severely compromised.
But the radiologist doesn't actually know that.
They don't.
A radiologist is looking at a static, frozen 3D picture from a CT scan. They are not hooking up pressure sensors and measuring the actual real-time volume of blood flowing through that opening while the patient is sprinting on a treadmill.
You've hit on the core issue. The ICAC realized that allowing a radiologist to label a shape as stenotic was allowing them to make a physiological diagnosis based entirely on an anatomical snapshot. It's jumping to a conclusion.
Right.
By banning stenotic and mandating the term slit-like, the nomenclature forces the doctor to remain completely objective. Slit-like is purely a geometric description. It tells the surgeon the opening is physically flattened by more than 50%, without making a definitive, potentially biased claim about how dangerous that flattening actually is.
It perfectly separates the anatomy from the physiology.
Exactly.
So the blood has finally managed to pass through the front door. We've exhaustively defined the vessel, the sinus, the pinpoint map coordinates, and the exact geometric shape of the door. Now, the blood must begin its journey away from the aorta and toward the heart muscle.
This is where it gets really risky.
This initiates the most hazardous phase of the condition, detailed in the next part of the OCDA framework, the course details.
The proximal course, the immediate anatomical pathway the anomalous artery is forced to navigate as it leaves the incorrect sinus, is overwhelmingly where the most lethal complications of AAOCA occur.
We introduced the abbreviations earlier, but we need to examine the physiological nightmare each one presents.
Let's begin with the two courses that sound deceptively similar, but the text insists must absolutely never be confused in a medical report: intramural and intraseptal, IM and IS.
The distinction between these two is a matter of life and death in surgical planning, right?
Absolutely. An intramural IM course dictates that the proximal segment of the anomalous artery travels inside the actual wall of the aorta for a variable distance before it finally punches through to the outside space.
The coronary artery literally shares its outer wall with the aorta itself.
Yes. It is physically tunneled inside the thick tissue of the main high-pressure pipe. And the mandate is to reserve the term intramural exclusively for this aortic wall tunneling.
Because an intraseptal IS course is a completely different anatomical reality.
Completely different. Intraseptal indicates that the anomalous vessel, most commonly the left main or the LAD, plunges downward and tunnels into the interventricular septum.
And that septum is the massive, thick wall of beating muscle that separates the right and left ventricles of the heart.
Exactly. So to be crystal clear, intramural means the artery is tunneling through the wall of the aorta, which is a structural blood vessel. Intraseptal means the artery is tunneling through the wall of the heart itself, which is a dynamically contracting muscle.
Confusing those two terms in a preoperative report would lead to a catastrophic misunderstanding of where the surgeon needs to cut.
It would be a disaster.
The third course outlined is the one that carries the most infamous reputation for sudden tragedy: the interarterial course, or IA.
Interarterial means the anomalous artery is routed precisely between the ascending aorta and the pulmonary artery. These are the two largest, most powerful, great vessels in the human body.
Right.
The aorta is violently pumping high-pressure blood out to the entire body, while the pulmonary artery is pumping blood to the lungs.
The fragile anomalous coronary artery is literally threading the needle between these two massive pulsating pipes.
It's a terrible place for a small vessel to be.
And visualizing the mechanics of this explains exactly why young athletes drop dead on the field. During intense exercise, the body demands oxygen, the heart rate skyrockets, blood pressure surges. Consequently, both the aorta and the pulmonary artery physically engorge and expand as massive volumes of blood rush through them.
Consider the implications of that expansion. As those two great vessels dilate under pressure, they act like a pair of physiological scissors, brutally pinching the anomalous coronary artery that is trapped in the narrow space between them. That pinching effect instantaneously severs the blood supply to the heart muscle, triggering immediate ischemia, a lethal arrhythmia, and sudden cardiac arrest.
It is a terrifying mechanical trap. To round out the 5 pathways, the last 2 are prepulmonic, PP, where the vessel navigates anterior to the right ventricular outflow tract, and retroaortic, RA, where it slinks behind the aorta.
It is also critical to understand that these courses are not mutually exclusive. A single anomalous artery can suffer from multiple hazardous routing issues simultaneously.
Like a combination of bad paths.
Yeah. The review emphasizes that it is exceedingly common for an artery to possess both an intramural course and an interarterial course.
So it tunnels through the dense aortic wall, finally exits the wall, and immediately finds itself trapped in the scissor crush between the aorta and the pulmonary artery.
Exactly. It's a double threat. If a patient has that combined nightmare anatomy, the core descriptor simply lists both, separated by a comma. For example, L AOCAR and IOCAR.
It captures the full scope of the danger in a few keystrokes.
It really does.
Now, because this proximal course is the primary driver of mortality, the ICAC demands advanced, hyperspecific metrics for this area. If you are a radiologist analyzing an advanced 3D CT scan, you're not allowed to simply write, "It has an intramural course," and move on.
Yeah, you have to prove it and you have to measure its severity.
Under the course details section of the OCDA framework, there are 5 advanced quantitative metrics that must be calculated and reported. The first is documenting the simple presence and the exact length in millimeters of the intramural segment.
That's the baseline metric.
I have to admit, reading this section left me a bit confused about the imaging mechanics. If a radiologist is looking at a grayscale CT scan, where tissues often blend together, how can they definitively prove that a tiny blood vessel is actually buried inside the dense wall of the aorta, rather than just resting tightly against the outside of it?
It's tricky.
A surgeon can easily see it when they open the chest, but how does a computer screen reveal that depth?
That requires a fascinating radiologic diagnostic trick, which the text highlights. Coronary arteries that are traveling normally through the mediastinum, the space outside the heart, are naturally encased in a protective sheath of epicardial fat.
Okay, fat.
Right? And fat registers with a very specific, recognizable density on a CT scan. However, the thick tissue that comprises the wall of the aorta does not contain that fat.
Oh, so they look for the fat to disappear.
Exactly. It's called the paracoronary fat sign. The radiologist traces the anomalous artery on the scan. If the bright signal of the protective fat suddenly vanishes, and the density of the tissue immediately surrounding the artery becomes indistinguishable from the density of the aortic wall, they have definitive proof that the artery has tunneled into the wall.
That is an ingenious use of the technology.
Yeah.
The sudden absence of the paracoronary fat sign confirms intramurality.
It's a very elegant diagnostic tool.
Once they prove the artery is inside the wall, they're required to measure exactly how deformed the pipe has become. This leads to the second advanced metric, ellipticity.
We introduced the concept of major and minor axes when we discussed the shape of the ostium earlier. Ellipticity applies that exact same geometric math to the entire length of the proximal course.
How do they calculate it?
To calculate the ellipticity index, the radiologist scans the intramural segment to find the spot where the vessel is most severely crushed, the most oval point. They then divide the major axis by the minor axis.
So a perfectly round, healthy, uncrushed vessel has an ellipticity index of 1 because the height and the width are identical.
Right. But imagine the radiologist finds a crushed segment that measures 3 millimeters wide, but only 1.5 millimeters tall.
Okay, 3 divided by 1.5.
Which yields an ellipticity index of 2. The higher that index number climbs, the more severely flattened the artery is.
The third and fourth advanced metrics deal with calculating the percentage of narrowing. And the mathematics they mandate here really highlight the historical chaos of medical data. The IGIAC forces the radiologist to report 2 distinct calculations for narrowing.
They want to be extremely thorough here.
The first is relatively straightforward. Cross-sectional area narrowing, or percentage CSA narrowing.
To determine the CSA narrowing, the radiologist relies on physical area. They measure the raw square millimeter area of the vessel at its absolute narrowest, most crushed point. This is the minimal CSA.
Okay.
Then they trace the artery further down its path to a point where it has safely exited the aortic wall and returned to a normal, healthy round shape. They measure the area there, that is, the distal reference CSA.
The text provides a remarkably clear example of this math. Let's assume the narrowest crushed segment of the artery has a cross-sectional area of 2.3 square millimeters, and the healthy distal reference segment has an area of 7.1 square millimeters. You divide 2.3 by 7.1, subtract that from 1, and you find that the vessel has suffered a 68% CSA narrowing.
But calculating the area narrowing wasn't enough for the ICAC. They mandate a second, more complex calculation, effective lumen diameter narrowing.
Why mandate two separate calculations? If the area is mathematically narrowed by 68%, isn't that sufficient data to determine the risk? Why force the radiologist to do more math?
Because cardiology is a vast field, and we have to ensure apples-to-apples comparisons. In standard adult cardiology, when doctors evaluate regular coronary artery disease like atherosclerotic plaque buildup from high cholesterol, the absolute gold standard measurement for risk is percent lumen diameter narrowing.
Okay, so it's a legacy metric.
Exactly. Cardiologists have decades of data correlating specific diameter narrowing to specific risks of heart attacks. But AAOCA is not caused by plaque blocking around pipe. AAOCA is characterized by the entire pipe being physically crushed into a flattened oval.
And you cannot accurately measure the diameter of an oval because an oval inherently has two different diameters, a long one and a short one.
That is the fundamental problem. So to allow a pediatric cardiologist to compare an AAOCA patient's risk to the millions of data points on standard coronary disease, they have to use a mathematical translation.
They calculate the effective diameter.
Right. They ask the computer, if we took the exact square millimeter area of this squished oval and magically reshaped it back into a perfect, uncrushed circle, what would the diameter of that perfect circle be?
The formula provided in the text is the effective lumen diameter equals 2 times the square root of the CSA divided by pi.
Let's run our previous example through that translation. We established the minimal crushed area was 2.3 square millimeters. If you plug 2.3 into that formula, it translates to an effective minimal diameter of 1.71 millimeters.
Yeah.
The healthy distal area was 7.1 square millimeters, which translates to an effective normal diameter of 3 millimeters.
Now we compare those two newly calculated diameters. 1.71 divided by 3 subtracted from 1, you end up with an effective diameter narrowing of 43%.
Consider the implications of those two numbers. The exact same crushed artery on the exact same patient yields a 68% narrowing if you calculate the physical area, but only a 43% narrowing if you calculate the effective diameter.
Wow. That discrepancy proves exactly why a strict, standardized formula is a matter of life and death. If one hospital in New York reported a 68% narrowing and a hospital in London reported a 33% narrowing for the exact same severity of defect, the global database would be an absolute disaster.
It would be entirely useless. Doctors would have no idea what the real thresholds for surgery should be.
By legally requiring every reporting physician to execute both calculations and to report the raw measurements used to derive them, the ICAC guarantees that the data flowing into the global registries is flawlessly harmonized.
The fifth and final advanced metric required for the proximal course is the acute angle of takeoff.
What does that mean?
This is a binary yes or no geometric descriptor. Does the anomalous artery branch off the aortic wall at an extremely sharp angle specifically, an angle less than 45 degrees tangential to the wall?
And why does the angle matter so much?
Because a sharp, acute takeoff angle can physically kink the vessel, much like kinking a garden hose. It drastically exacerbates the restriction of blood flow.
All right, we have exhaustively mapped the specific anomaly. We know the vessel, the sinus, the map coordinates the shape of the door, the perilous pathway, and the mathematical severity of the crushing. Now we need to zoom out and assess the rest of the heart's environment.
Yes, the D and the A.
Right. This brings us to the final letters of the OCDA framework. The D stands for dominance.
Coronary dominance is a foundational concept in cardiac anatomy. It simply asks, which side of the coronary system is doing the heavy lifting to supply blood to the posterior or back wall of the heart?
Yep.
Technically, it is defined by whether the right coronary artery or the left circumflex artery gives rise to the posterior descending artery and the posterolateral branches.
The text provides the baseline statistics.
Hmm.
Roughly 84 to 88% of the human population is right dominant. Only about 8% are left dominant, and between 3 and 8% have a codominant system where both sides share the load equally.
What is truly fascinating about the inclusion of dominance in this mandatory checklist is that the authors explicitly admit they have no idea if it matters.
Wait, really?
Yeah. The text states that it is currently entirely unclear whether a patient's coronary dominance plays any significant role in the pathophysiology or risk profile of AOCA.
Which raises an obvious question. If the world's leading experts don't know if dominance affects the risk of sudden death, why mandate that every radiologist in the world spend time documenting it?
Because that is the ultimate purpose of building a risk-agnostic registry. You cannot discover a correlation if you do not capture the data.
They're playing the long game.
Exactly. They are demanding the collection of dominance data today so that in 15 years, a supercomputer can analyze 30,000 patient records and definitively answer the question.
I see.
It might turn out that a left-dominant patient with an intramural course has a 40% higher risk of ischemia than a right-dominant patient with the exact same anomaly. If we don't force doctors to log the dominance now, we will never unlock that future insight.
It is incredibly forward-thinking data architecture. The final piece of the OCDA puzzle is the A, additional findings and comments. What other threats are lurking in the neighborhood?
Well, the heart is a complex organ, and an anomaly like AOCA rarely exists in a perfect, pristine vacuum. The ICAC encourages clinicians to meticulously document any other coexisting pathologies that could compound the patient's risk.
Like what?
A primary example is a myocardial bridge.
We mentioned the intraseptal course earlier, where the artery dives deep into the dividing wall of the heart. A myocardial bridge sounds similar. It's when a coronary artery that is supposed to be riding safely on the surface of the heart suddenly dips down, tunnels directly into the contracting heart muscle for a short stretch, and then resurfaces.
Yes. And much like the interarterial scissors effect between the great vessels, a myocardial bridge subjects the artery to violent compression.
Because the muscle is squeezing it.
Every single time the heart muscle contracts to pump blood, it literally squeezes the tunneled segment of the artery. If a young athlete is suffering from an anomalous origin and a myocardial bridge on the exact same compromised vessel, their risk of sudden ischemia multiplies exponentially.
The nomenclature requires the doctor to list the specific vessel involved, the location of the bridge, the length of the tunnel, and how deep into the muscle it goes.
They also request documentation of coronary fistulae, which are abnormal rogue connections bypassing the capillary bed and dumping directly into a heart chamber, as well as the presence of any standard atherosclerotic plaque buildup.
We also circle back to the pillar concept we discussed during the vertical topography mapping. The intercoronary pillar is that thickened column of aortic tissue.
Right.
The text highly recommends explicitly noting if the proximal course of the vessel forces it to travel behind or through this dense pillar, as it is a major suspect in causing dynamic narrowing during the cardiac cycle.
There is also a very specific, uncompromising clarification they make regarding how to describe the intraarterial course. They forcefully reject the old subjective terms high and low to describe where the artery travels between the great vessels.
Because that's too subjective.
Way too subjective. Instead, they demand the terms pulmonary facing if the artery courses primarily between the aorta and the pulmonary artery, and RVOT facing if it courses between the aorta and the right ventricular outflow tract.
It strips away all subjective ambiguity. What one surgeon considers a high path, another might consider low. But pulmonary facing is an absolute, undeniable anatomical truth. It leaves zero room for misinterpretation.
Exactly.
So, after this monumental year-long effort, the ICAC has forged this incredible, comprehensive, uncompromising new language. But a new language is useless if nobody speaks it.
That's the real challenge.
Right. How do you force busy, overworked doctors across thousands of different hospital systems to actually abandon their old habits and use this complex framework in their daily practice?
You build an app.
The brilliance of the ICAC is that they didn't just publish a 20-page academic paper, toss it into the ether, and cross their fingers that radiologists would memorize the formulas. They built a technological enforcement mechanism.
The implementation strategy is arguably just as vital as the nomenclature itself. The task force developed a dedicated standalone software application. They initially built it in Python using tkinter and the Python imaging library for the interface.
Wow.
Then, recognizing the need for global accessibility, they converted the underlying logic into R code so it could be seamlessly embedded directly into a cloud-based web application.
The elegance of that tech solution is stunning. A busy radiologist doesn't have to refer back to a dense journal article to remember the difference between CSA narrowing and effective lumen diameter. They simply log onto this app, and they are presented with an intuitive interface of drop-down menus, multi-select list boxes, and straightforward text entry fields.
Figure 8 in the text displays screenshots of this interface, and it is a masterclass in applying modern user experience design to high-stakes medicine.
It's so simple.
The doctor literally just clicks their way through the patient's anatomy. Click, right anomalous artery. Click, left sinus. Click, intramural course. Click, type 2 ostium. Click, slit-like morphology. They type the raw measurements of the major and minor axes into a box, and the software's backend automatically executes the complex math, instantly calculating the ellipticity index and the effective lumen diameter narrowing.
And the true magic happens at the very end. Once the radiologist finishes clicking boxes, the app automatically generates a perfectly standardized, flawlessly formatted, grammatically correct paragraph of text.
Ready to go.
The doctor just clicks copy, switches over to the patient's electronic medical record, and hits paste.
It virtually guarantees total compliance. By giving doctors a tool that actually saves them time, the ICOC is silently ensuring that every single hospital in the world inputs the data with identical phrasing, identical punctuation, and identical mathematical foundations.
If we step back and view the grand strategy here, this standardized, machine-generated text is going to feed directly into overarching international multi-center registries. The review expresses a strong hope that the ICAC will foster the creation of these unified registries, or that massive existing organizations like the American College of Cardiology will adopt this nomenclature as the mandatory standard for their own databases.
And once that flawlessly structured data is pooled together on a global scale, that is where the true revolution in cardiac care begins.
Because right now, the data is too messy to trust.
Exactly. But once you have 50,000 patient records structured identically, without a single confusing ACAOS or stenotic label to muddy the waters, you can unleash advanced data analysis.
Machine learning.
Yes, you can train machine learning algorithms on this pure data. The algorithms will possess the statistical power to finally look at the outcomes and determine which specific microscopic combinations of factors are the true drivers of sudden cardiac death.
So it might find a combination we'd never think of.
Exactly. It might reveal that an anomalous right artery with an intramural course is not statistically dangerous on its own. But the algorithm might discover that an intramural course combined with a slit-like ostium, combined with an effective lumen narrowing of strictly greater than 54%, carries an 80% risk of a lethal arrhythmic event during extreme exertion.
We will finally possess the mathematical certainty to know exactly which metaphorical pipes under the driveway are destined to burst under pressure.
Yes. The anatomical data will finally be able to speak to us clearly because we took the time to painstakingly remove the noise of bad translation.
That brings us to a final, profound thought for you, the listener, to carry away from this deep dive. Right now, this rigid nomenclature is primarily about creating a common, unbiased language for doctors to communicate with each other across specialties and borders.
Right.
But imagine the medical reality 10 or 15 years from now. Imagine a future where this risk-agnostic data has become so robust and so deeply analyzed that an AI system can evaluate a standard 3D heart scan of a 10-year-old child.
It's incredible to picture.
It instantly maps their anomaly using this exact nomenclature, cross-references those coordinates with millions of identical data points, and tells the parents with absolute statistical certainty whether their child can safely pursue a career in competitive sports, or if they require a tiny preventative surgical intervention before they ever step onto a high school field.
It changes everything.
Language is not just a tool for present-day communication. When applied with this level of rigor, it becomes the literal foundation of future prediction. It turns the terrifying, murky waters of a congenital heart diagnosis into a clean, precise, actionable map for survival. Thank you for watching The Funnel Effect.